So good evening, everyone. Welcome again to the ACNS Win webinar. This is the fourth in our series for this month. And again, we are very happy to have three great guest speakers for us today, coming from every parts of the world. Our first speaker is from Hirano, is from Japan, and then Professor Angela from US, and then Prof. Yang from China. And we also have a few great discussants with us. We have Arion and Prof. Arion here. Prof. Suresh is here with us today. We have also our Prof. Ahmad Fawad, who always comes in. Oh, yes. Hi, Mirna. Nice to see you. Prof. Mirna has joined us. And Yang, yes. So very nice to see all of you here today. And of course, always together with us together with me is Abida to co-chair the whole thing. So I will actually hand over to our chair today. Is our chair around today? Is Prof. Eugene Liao around, or is he not around?
No, we haven't seen him.
He hasn't come in. Okay, it's all right. For the moment, I'll just help to chair the thing. So I think we'll start off with our first speaker for today. Our first speaker is Dr. Marina Hirato. Okay, she's a senior resident of neurosurgery, Department of Neurosurgery, Showa University Hospital, Tokyo, Japan. So without wasting much time, Marina, are you ready? You can start to share your screen.
Okay, I share my screen. Can you see that?
Very nice, very nice.
Okay. Can you see my presentation?
Yes.
We can.
Okay, thank you. So I'll start. I'd like to thank Dr. Yagakato for kindly inviting me to speak here again. Thank you. And now I'm going to speak about NBCA embolization for hemodynamic stress-induced peripheral aneurysm. Peripheral aneurysms induced by hemodynamic stress are common in 𝑬𝒎𝒃 disease and often lead to rebleeding. And however, they are located in the deep peripheral brain, so open surgery is difficult as well as endovascular therapy due to difficult catheter access. So we report 2 cases using a super fine microcatheter, 𝑑𝒓𝒄 Nano, which provided access to peripheral aneurysms and led to treatment. A 55-year-old man came to our hospital due to headache. At first, his headache was not so strong, but gradually worsened, and he visited our emergency department. He'd already been suggested 𝑬𝒎𝒃 disease by brain scan 10 years ago, but he didn't check more details about it. Here is CT scan on admission. You can see the intraventricular hemorrhage, and it was associated with intraparenchymal one, suggesting that it was the origin of the bleeding. And 3D CTA showed the distal side of left IC cup disappeared, and that seemed 𝑬𝒎𝒃 disease. But on the other hand, the left carotid canal was very narrow, so we suspected hemodynamic stress due to congenital hyperplasia. Like this one. Very narrow canal. Then, the distal side of ophthalmic artery didn't show by the left IC angiography. The left vertebral artery, and left vertebral artery angiography showed the collateral circulation of the left MCA and ACA came from left PCA. And basal CT showed the peripheral aneurysms on the left distal PCA. The location of the aneurysm was consistent with the source of bleeding. Its size was about 2.7 millimeter, like this, and it was present on the peripheral branch towards the temporal lobe cortex. On admission, we started the antihypotensive treatment and did the DSA on second day. From when we diagnosed the cause of IVH was hemodynamic stress, we've decided to do bypass surgery, but I wondered how to avoid the rupture to the bypass. I thought if we could guide the microcaster to the parent artery of the aneurysm, we could safely embrace it. Because the aneurysm was considered to be sufficiently peripheral, thus by limiting a very small amount of embolization, we thought it allowed collateral vessel to develop even if the mother vessel occlusion was performed. Then I consulted my boss and he said the microcaster deflector can be. So we decided to do embolization on the third day. At first, we did selective angiography of PCA by using the microcaster and distal access caster. You can see the aneurysm here, very small one, like this. Before the operation movie, I'll show a schema. First, we choose marathon, whose vital diameter is 1.5 French as the microcaster, but it couldn't reach the target artery. We changed to deflector, which the super sharp one. It could be guided to the distal artery smoothly. And also, the radiopaque region of the tip reached the parent artery of the aneurysm, like this. Okay, here is the operation movie. We tried to use marathon, but it couldn't reach there. This one is the tip of marathon and kick back. And we choose deflector. This one is the tip of deflector. Go up smoothly like this, and out the diameter. The tip was very near from the aneurysm. And from this side, we injected 20% of NBCA to embrace. And final view, we check the punishment of the aneurysm. After this operation, he was discharged home without any symptoms. Case 2 was 55-year-old woman. She went to a local hospital due to a headache and was referred to our hospital because it appeared cerebral hemorrhage by CT scan. She had never had a brain scan and had no family history of 𝑬𝒎𝒃 disease. CT scan on admission showed a light intraparenchymal hemorrhage, and this site suggested the origin of the bleeding. From CDCDA, both isotope weren't shown, and it seemed 𝑬𝒎𝒃 disease. By the right ICA angiography, anterior choroidal artery was well developed and refracts through MCA and ACA region. Basal CT showed two peripheral aneurysms on the right distal anterior choroidal artery, this one and this one. Same as case 1, we did embolization on the 13th day. Selective angiography of anterior choroidal artery was done by using microcaster and distal access caster. This time, we also checked the motor evoked potential monitoring. Deflector was guided to the distal side smoothly again and reached just proximal of the aneurysms. You can see the aneurysm there. And deflector go up and go up, and finally we injected 20% of MCA from here, and we can see the two aneurysms. And the catheter was immediately removed after confirming the absence of aneurysms. Though MRI shows scattered cerebral infraction on the distal side of the parent artery, fortunately, she was discharged home without additional symptoms. Referring to the previous studies, the prevalence of aneurysm in Murmur disease is estimated to be around 8%, and the incidence of aneurysm-related cerebral hemorrhage is estimated to be between 14 and 25%. Based on the vascular pathology of Murmur disease, these characteristics are thought to increase the potential for aneurysm formation, change, and rupture when hemodynamic stress is applied here. Several reports about treatment incidents that surgical revascularization leads to the elimination of collateral artery aneurysms, but actually there are also not eliminated cases we experienced. In recent years, endovascular aneurysm embolization has also been used to prevent rebleeding. A systematic review of case reports and case reads with ruptured collateral artery aneurysm in Murmur disease patient was published in 2022. This study showed conservative therapy was most selected, but it had high strategic change rate due to rehemorrhage. Endovascular therapy also had high rate of strategy change due to access difficulties. As I mentioned before, the rupture rate in conservative therapy is high, 40%, and over half of them occurred during the first 35 days after bleeding. One of the reasons why conservative treatment had been selected was the belief that cerebral aneurysm caused by hemodynamic stress of pseudoaneurysm. However, studies that have performed pathological analysis of aneurysms from open surgery case has shown that half of them were true aneurysms. Based on these findings, aneurysm should be considered for treatment urgently, as expectation seems associated with a high rupture risk, although some aneurysm may thrombose spontaneously. And direct surgical treatment with or without revascularization was the initial treatment strategy in 21% of cases. The aneurysms were scared more often by patient vessel sacrifice and aneurysm excision. However, depending on the aneurysm, it is quite difficult to approach directly, and its complication rate was the highest of any strategy. Endovascular therapy had both low relapse rate and low complication rate, but the follow-up period period of this study was short, and the number of patients was not so large. It seemed a good way to prevent relapse, but the weak point of this strategy is high rate of procedure failure due to access difficulties. These are superfine microcasters being used in Japan now. Especially, Diffractor Nano had a very narrow tip and its outer diameter is 1.53 French, and 5 mm from the tip marker is radio pale, and this area is extremely soft. So we think these casters will be helpful to overcome the weak point of endovascular therapy as our cases. Here is the conclusion. Endovascular embolization seems to be effective in preventing the rupture of peripheral aneurysms. The Diffractor Nano allows access to more distal and smaller vessels, which may contribute to higher procedural success rate. Thank you.
Thank you very much, Marina. That was a lovely presentation. So now I'll open up the floor to our discussants. Start off with, any one of you want to start off with a question for Marina? Arion or Prof. Suresh or Mirna or Prof. Hashi? Question for Dr. Hirato? Any questions?
I would, may I please start?
Thank
Dr.
you.
Hirato, good afternoon there to you in Japan, and thank you for your presentation. Wonderful work put together. It's great to see some new advancements in the field, because the opportunity you have to deal with moya cases gives as well additional information to most of us in other areas where the incidence of disease is either rare or not. So the opportunity for us to be exposed. I was wondering, a technical question, where you are currently studying and working, you conducting any basic science research work on the moya disease?
For me, basic research.
Yeah. For example, at your center, are you studying maybe the flow dynamics of the aneurysm and the wall changes of the aneurysms of these case presentations, or maybe during surgeries you have been able to collect tissue samples from the vessel wall and then conducting genetic research, or for that matter, epigenetic of the vessel wall composition.
Yes, and I checked the previous studies, and especially the pathological study. They said these pathological characteristics are one of the reasons why the peripheral aneurysm ruptured, and especially under the hemodynamic stress condition, these pathological characteristics change to more fragile one and rupture it, they said.
Thank you. Thank you, doctor.
Thank you.
It's a nice talk, Dr. Marina. Can I go ahead?
Yes, please go ahead.
What I wanted to know is that we have also seen the peripheral aneurysms, but mostly what we had been seeing earlier in the middle cerebral artery distribution in the distal branches over the convexity region. There, as you have described, what we used to do is that we used to excise that, and it used to be better seen on the MRI and MR-angio and all those things we used to do. But the technique which you have told, it's excellent, because the thing is that if these are deep-seated aneurysms, as you have told, it's a very nice technique. But and the complication rate is also less. I just wanted to know one thing from you is, since moya disease is much more common in Japan, is the incidence of these aneurysms are much more in Japan? Have you worked out the incidence as compared to the other parts of the world? That's what I want to know.
It seems the genetic reason caused the moya disease, and especially in Japanese people has the genetic instance.
Professor Yoko, how many such patients you have seen at your place? The distal aneurysms in your place, and what is the usual location in these distal aneurysms?
Not so common actually, but the IVH patient, if we met the patient with IVH, we always consider about moya disease, and we have to check CTA and also DSA. And the most of patient, especially adult patient, have never diagnosed as moya disease because there are no symptoms till the adult, so till grow up. So yeah, we have to check it, but not so common. But yeah, sometimes we met.
I'm not sure you understood what he said, what she said. So the kind of the choroidal artery, that is the most the weakest point.
Yeah.
Where it is, that make one of the cause
That
of the
will be the-
ventricular hemorrhage. Yes.
Yes, yes. And Abhida, you have got a good endovascular department at your place. See, what I wanted to know is that we have got all these catheters to tackle these deep-seated aneurysms if required.
We have. I'm not sure about this deep fructose. This is the first time I'm seeing that. So the others we have. We have all of them available.
Because the reason is that, say, if there is such patients, I totally agree with you. Smaller is the aneurysm, distal is the location, more are the chances of rebleed. So there might be places like they might not be having the special catheters, as Dr. Marina has told. I just wanted to know from Abhida that if there is such patient, we are able to tackle these places at your place, or maybe these are usually available catheters in our country. That's what I want to know.
So the catheters are readily available. I'll just check with this new one that she has said.
Okay.
But in our country, most of these catheters are available. They maybe come in a little late, but ultimately they are available.
Okay, nice.
But
Thank you.
now you don't see too many peripheral aneurysms. That at least I have not seen that many. I've seen moya with basilar top aneurysm, which has bled. And then it becomes a challenge to treat because the other vessels are not very well formed. But I haven't seen peripheral aneurysms too many. So I'm just wondering if we don't do anything and just treat the moya, what happens to these aneurysms? These peripheral aneurysms.
What is the answer to that? If we treat them conservatively and we do not do anything to the aneurysm and we
But
treat
treat the
moya,
bypass. Yeah, treat moya. Then what happens to the aneurysm?
then what's the outcome in these patients? Dr. Marina.
So just I want to make it clear of the
Yes.
material. So
Yes.
that you're talking about the aneurysm, the with moya or
Yes.
moya in the moya vessels,
With
or
moya
just
and this aneurysm.
just associated with moya disease, which you are talking about.
Yes, yes.
Because if in the aneurysm in the moya is quite difficult to treat, I think. Maybe
Yoko, what Abhida wanted to know is that if there is an aneurysm in the locations which she has shown and there is associated moya, is it okay if we treat the moya and the aneurysm will disappear with the hemodynamic changes? Is it possible? That's
yes,
what
maybe
we want.
yes, maybe she can answer, I think.
Yes,
Marina?
yes, Marina.
Yeah, if the aneurysm was shared aneurysm, we can eliminate it by the bypass surgery. But the half of them were true aneurysm, the past studies said. So if the aneurysm was a true aneurysm, we can't eliminate it by only bypass surgery. So we experience like the patient who done the bypass surgery, but they leave bleeding one. So we experienced before. So that is because.
So obviously, Abhida, I think probably the aneurysm has to be tackled even if we tackle moya. That's what she wants to do.
Okay. Thank you. Thank you, Dr. Marina. Thank you, sir. I think if there are no other questions, we can move to the next one, shall we?
Yeah, I know. Thank you very much, everyone. Thank you. It was very, very exciting discussion going on. Okay, so we'll go on to our next speaker. Our next speaker is Professor Angela Richardson. Professor Richardson, are you ready? Yeah, okay. She's from the Department of Neurological Surgery, Biochemistry, Molecular Biology, Indiana University School of Medicine. And today she's going to present to us something very interesting. So let's sit back and listen.
All right, can you guys see that okay?
Yes, everything's good.
Okay, so today I'm going to talk about this case that I thought was interesting, and it required me to think a little bit about how to treat this patient using implanted brachytherapy for a fourth-time recurrent meningioma. So first disclosures, I just want to say I am going to be talking about a technology using GammaTile, and I am site PI or co-PI for 2 trials for that. This was not a trial patient. This isn't a pathology that there's an active trial for, but just to be upfront about that. So this was a 50-year-old gentleman who was referred to me for a current left frontal meningioma. He had a very long neurosurgical history. He was initially diagnosed in 2009 when he presented with seizures. He had surgical resection of the lesion, which was reportedly large at the time. I didn't have the imaging as this was done in another facility. The pathology for that was a WHO grade 2 choroid meningioma with a Ki-67 of 10%. He did not follow up, and he eventually represented with confusion and headache 9 years later. With that recurrence, he underwent re-resection, and pathology at that time was WHO grade 1, which I find to be a little suspicious. We were not able to get those pathology specimens, but would be unusual for meningioma to be a lower grade the second time around. These are his films from 2018, so this is between that first and second resection. So you can see this large left frontal lesion, very significant surrounding edema, and its proximity to, but not that close at this point, to the superior sagittal sinus. So he did pretty well there. In 2020, he then developed a right-sided weakness with tumor recurrence and underwent his 3rd surgery at this time. And again, you can see this lesion has recurred in a similar location, but now is much closer to the superior sagittal sinus. You can also see in his skull old burr holes, and you can see the skin is undergone retraction in certain areas with incisions. This was also WHO grade 1, and postoperatively, he had a moderate aphasia at this time, which really impacted his quality of life and ability to work. And then after that, again, this is all before I met him, he had another recurrence with this much smaller lesion in 2021. And so at that time, he underwent gamma knife radiosurgery to the lesion as it was under 3 centimeters. So he was eventually referred to us at Indiana University. His treating neurosurgeon thought he required care at a larger tertiary center. Due to his prior surgeries, there was significant concern about wound closure if another surgery were undertaken. His initial surgery had like a horseshoe or trapdoor incision, and then the 2 other surgeries used an S-shaped incision. So his scalp had, concerns for limited vascularity given these prior surgeries. So I saw him in clinic. This was his imaging at the time. Again, you can see this tumor's recurred in basically the same spot. You can see encephalomalacia related to prior interventions. And now the tumor is again kind of up against the superior sagittal sinus. So just a quick review about choroid meningioma. So this is a rare meningioma subtype. I have some pictures here of what it looks like on H&E staining. It makes up less than 1% of intracranial meningiomas, so certainly not common. It gets its name from histologic features, which it shares with chordoma, and it seems to have a more aggressive biology, and it is a WHO grade 2 lesion, so I'm assuming his tumor was really grade 2 the whole time. And this is just a timeline showing his care for this tumor. So in 2009, the initial diagnosis and resection, and then 9 years to recurrence and re-resection, but then only 2 years to recurrence and re-resection, 1 year to recurrence and gamma knife, and then 1 year till I saw him in follow-up. And so if I can go back real quickly, this is what it looked like when he presented to me, and this was what it looked like when it had been gamma knifed. So definite signs of growth, not swelling that you can see from radiation. And so we kind of had this progressively quickening course with recurrence. So we discussed his case at our multidisciplinary tumor board. And kind of the options we talked about, we could resect this for the 4th time. Obviously, concerns with surgical risk. He was worried about his aphasia being worse, and wound healing certainly an issue in a patient like this. We talked about radiation, but external beam radiation, there were concerns for toxicities. He's already had gamma knife, and there's no real good medical options to treat these tumors. And so the consensus recommendation was to consider him for re-resection and GammaTile or implanted brachytherapy placement. And I referred him to my ENT colleagues to look at his scalp to try and figure out the best way to get a closure and consideration for a free flap at that point. So what is 𝒂𝒂𝒑? It's a type of surgically targeted brachytherapy. So it's implanted at the time of surgery. And this, just for anyone who's not familiar with this technology, external beam radiation therapy obviously comes from outside. It radiates the area, but you get, spread around the tissue, and this can be different depending on the type of radiation that's delivered, whether gamma knife or LINAC. Internal radiation or brachytherapy is in the form of typically seeds that are implanted, and if you implant it in a cavity, ideally you'd be able to get high local doses with pretty rapid fall off and low damage to the surrounding tissue. So brain brachytherapy is not new. There's been reports for many years in high dose rate brachytherapy, so temporarily placed radiation sources that could then be removed were used initially, and that has progressed kind of more recently to lower dose rate brachytherapy, and those are permanently placed radiation sources. And the concerns for this, some of them are the dosing. So ideally you want to get these brachytherapy seeds kind of equidistant apart, and trusting and trying to get them to sit in the brain, whether they're in these ribbons or individual seeds, to get them to sit and get consistent dosing can be challenging. So some of the downsides in the past, again, uneven spacing, where you would have hot areas with an increased dose, but also increased toxicity, and cold areas without therapeutic dosing, as well as direct contact with the brain. So very, very high doses at that area of contact. So this is a graph kind of showing distance from the brachytherapy seeds and the dose. And so right where the seeds are touching the brain, you're getting very, very high doses of radiation that then fall off pretty quickly within, 3 millimeters. And then again, 5 millimeters. And if you're a centimeter away, the brain's getting much, much less radiation. So 𝒂𝒂𝒑 is a commercial product. It's a specific type of brachytherapy. They don't pay me to talk about them, but we use them at my institution. It is FDA approved for newly diagnosed malignant neoplasms and also for recurrent intracranial neoplasms. So in the recurrent setting, it can be used and is approved for more benign pathologies like meningiomas, even though I think we'll all agree that recurrent meningiomas aren't necessarily benign. The way these are designed is to give more even spacing for more even dosing. And so this shows one of these tiles. They're 2 centimeters. They're in a collagen sponge, so think like a Duragen material. And these are about 4 millimeters thick. The seeds are placed offset, so they're not directly in the center. They're 3 millimeters from one surface. And so that's the surface that typically is placed towards the brain. So that gives you a 3 millimeter offset from the brain with the radiation seed. Each of these seeds, and there's 4, you can't really see it here, but they're cesium-131, which has a half-life of 9.7 days. And there's a pretty rapid fall off, again, at distance from the seeds themselves. So if this is put on the surface of the brain, there's 3 millimeters away here, you get that fall off. And again, this is that graph. And so, it came in the wrong order, but the 3 millimeters gives you, so the brain is getting at most kind of this dose after you've offset this 3 millimeters, and you get more rapid fall off. There's a registry where patients who are getting implanted with these are getting recorded, and the company is collecting data on safety and things of that sort. So the most common indications, and this follows what we've seen at our institution, is recurrent gliomas. We haven't done too many metastases except for on trial. And then meningiomas is a less common indication. And this was the first case of meningioma we had done with these at our institution. So some of the hurdles when we were talking about this case, I had an initial conversation with my ENT partners. He'd had multiple bone flaps made for each surgery. So there were numerous burr holes throughout. So the bone was very uneven. And that is not a great surface to place a free flap on in terms of healing. So they recommended initially a custom cranial implant. The literature in the ENT kind of community demonstrates improved outcomes compared to something like a titanium mesh. So when I discussed this with the GT MedTech team, what I hadn't thought about was that PEEK, which is what our custom cranial implants are typically made of, doesn't block radiation as efficiently as native bone. There's much less shielding due to its density. And these patients, once they're implanted, they undergo monitoring in the operating room once the skull's back on to ensure that there's not excess radiation coming through the skull, and they have to meet a threshold to meet discharge criteria. And in this case, again, it's a superficial lesion, so the tiles are going to be placed at these dural margins. And so if we put in peak, there was concern that we wouldn't get enough blockage of that radiation to have him safely meet discharge criteria. So we further discussed this with ENT and actually made the decision to use the patient's own native bone, but supplement that with mesh and methyl methacrylate. And these are just some CAT scans of other patients just to kind of, visually bring this point home, right? So normal bone's pretty dense on a CAT scan, but a peak implant is much less dense. And that's compared to titanium mesh, which again is more dense. And if you supplement that with methyl methacrylate, you will get more shielding of the radiation. And so at surgery, we performed the opening in combination with neurosurgery and ENT. The meningioma was resected completely. The surgery itself was pretty uneventful. ENT harvested a latissimus flap, and the gamma tiles were placed. We actually flipped these superficial tiles, and so that reduces the offset to only 1 millimeter. So there's a higher dose at the dura where we flip those. And we did a bone and mesh cranioplasty with bone cement, which I used one that our orthopedic colleagues use that has antibiotic in it because just concerned for infection with multiple surgeries. And then the free flap with anastomosis and closure was performed by ENT. And you can see the free flap with the split thickness skin graft there on his head. This is his post-op scan. You can again see the seeds from the radiation implanted brachytherapy evenly distributed around the cavity. This is the free flap, very bulky at the time. He remained at his neurologic baseline. He was recommended for rehab. And again, pathology was a choroid meningioma, and this time the Ki-67 was greater than 10%. He had his pre-existing weakness and social reasons due to his home situation, went to rehab, and he was seen in clinic doing well. This was his MRI at 6 months, so this still looked really good at that point. He's due for another MRI, but he has been doing well clinically. So just some discussion of data with brachytherapy and recurrent meningiomas. This is from Dr. Brockman, whose group kind of designed these gamma tiles and meningiomas. So they looked at 20 patients with recurrent, previously rated meningiomas. And here in this graph, they're looking at freedom from local progression. And so this is kind of the rate before implantation, so prior surgeries, and this is after implantation. So again, it seems like it's pushing out recurrence. 18-month progression-free survival was 89% after resection plus gamma tile and 50% after prior treatment. But I think this data is obviously still maturing. And there was only a 10% rate of radiation necrosis, none of which required reoperation, because that's one of the main toxicity concerns. This is another study by Dr. Koch looking at brachytherapy seeds in meningioma. So again, a different format of radiation. This is the seeds with kind of the problems I spoke about before, but this is time to progression of either atypical or malignant meningiomas following brachytherapy seed placement. And obviously the malignant meningiomas have a much faster rate of progression than the atypicals, as early as 5 months to get to the 50%. And overall survival also doesn't seem as different for the malignant versus the atypical. So in conclusion, implanted brachytherapy is becoming more common at certain sites in the US. And I think some of that's due to this new technology where they're implanted in these tiles, the Durgen type sponges or something that neurosurgeons are very familiar with. So it's has a little less of the technical challenges. The operating room staff, the surgeon, you're not really exposed to a lot of radiation because they're pretty quick to put in. And these technical issues of trying to get even spacing are not such a concern. The most common indications that are being done right now with this is recurrent glioma, but there are ongoing clinical trials to look at in metastases to look at safety and efficacy. So that's a randomized controlled trial, or safety and feasibility in newly diagnosed glioblastoma. And so at Indiana University, we're primarily using these for trial patients or off trial in patients with limited other options. So again, those recurrent gliomas or something like a fourth time recurrent meningioma with a history of radiation. So I just want to acknowledge our kind of entire team. It takes a lot of people to do these cases. We need the radiation oncologists to come to the OR, the radiation physicists, and we get help planning the number of tiles to order from the company. they're made to kind of order as the radiation falls off pretty quickly in time. So that was my talk.
All right. Thank you so much, Angela. It was a fantastic insight into treating difficult meningiomas. I think all of us have had experiences. So now I open the questions to the floor. Anyone wants to go first?
Yeah, Angela, if no one is starting, let me start. Say the thing is that if we go into the retrospect, the story what this patient had, say, are these choroid meningioma more likely to recur as far as the pathology is concerned?
They have higher rates of recurrence and progression, yes.
Yes, number one. Number two is what I see is 2021, the patient was given gamma knife, the lesion was not very large, correct?
Correct.
Do you think that the gamma knife at that time, in 21, has led to the increase in the size of the lesion?
You know, we thought about that and discussed it pretty extensively. The size increase was very significant,
Yes.
kind of beyond what we would have expected for radiation related. And I showed one scan between the gamma knife and treatment, but we had a couple other ones because planning this surgery took some time and it continued to grow over that time period. So again, we didn't, we thought it was due to active tumor, and that's what the pathology did end up showing.
The other comment is that will the house agree to my recommendation, not going into the details of what treatment was provided, what should have been provided in 2021, looking at the size of the lesion, the location of the lesion, what I feel, if probably we could have removed the lesion at that time.
Yeah, I didn't see him then. I think the concern was the patient was pretty resistant to a fourth surgery when I saw him. So I think he was resistant then as well. And so I think that was offered as an alternative. But I agree. I think with his history, that was probably not likely to provide long-term success. And I don't know the data on choroid meningiomas specifically in external beam radiation, if it tends to be efficacious or not.
Yes. The other thing is that as you are telling that these are the lesions which are more likely to recur, then in 2009 when the patient was operated, probably if the radiotherapy local could have been given at that time, that might not have led to the recurrence. Means it is going into the retrospect and the pathology of the tumor. That's what I feel.
Yeah. And I mean, grade 2s, I think that's kind of always the question we at least have is, like, do you radiate if you think you got it all out? Do you wait till it comes back? And he was lost to follow-up. So I guess those conversations were never even really able to be had. But I think hopefully we can come up with some better strategies.
Yes, I think we have a few people in line.
One thing more. I think Abhida will agree to me that we don't face such many problems with the patients if we, at the time of gamma knife, if in our country we go after the patient and tell him that no, you should get operated, then many times they get convinced. I think Abhida will agree to me on that.
Yes.
And they are doing more aggressively these lesions than what we are doing. It's, I really, KEM Hospital, I respect them. They are doing a lot on that.
I think we have a question from Huipam. Huipam, you want to?
Yeah, I have two questions. One question is that do you have any evidence comparing the intraoperative radiotherapy only compared to the permanent implant of the radiotherapy source within the brain? So is there a difference between the two?
Oh, like the temporary high rate radiation versus the lower rate? I haven't seen any of that. In the low dose rate, these seeds, they're permanently implanted, but by about day 14, the amount of radiation is sort of back at background. So even though the seeds stay around, the radiation is gone. But I haven't seen data directly comparing the two. And I think that's probably because they tend to be the high dose implanted brachytherapy, at least I think, is very limited in which institutions are comfortable doing that. I think logistically in the operating room and shielding the operating room staff and all that can be very challenging with those higher dose rates.
Yeah. And also, I've seen one choroid meningioma in my practice, but it was in suprasellar regions. And also for the other lesion like recurrent meningioma in the deep location like that, can we place the brachytherapy radiation source deep in the brain in that situation?
So typically no, because at least the current sort of standard that everyone's using for these is you need to be at least 5 millimeters from the brainstem or any of the cranial nerves. So otherwise you would definitely be getting over kind of the limits of exposure to those very critical structures. So yeah, it's still limited use cases where you have to be kind of far away from all those structures. The other thing people always ask too is like when people are discharged, are there any precautions? And in general for this, the amount of radiation getting through the skull is so limited that the only real precaution is we tell people not to sleep next to someone for the first couple of weeks because want your head super close to that. And we in the hospital will have the nursing staff aware that they have implanted brachytherapy so they don't get a pregnant caregiver for the other precautions.
Yeah, thank you for the answer.
Thank you. Prof. Arian, you want to go ahead?
Thanks. Thanks, Doc. Dr. Richardson, I'm so happy that I finally had the opportunity to attend a talk. I know how you have been able to combine, and actually, I don't know how you manage the time to put together your research work in the lab and then doing the neurosurgery. It must be very challenging, but this case was a talk through and through on how you could really think of outside the box to find solutions to take care of your patient. I could see there how you took on the challenges of reoperating and then teaming up with colleagues going and coming in to help you guys from the outside department. That's amazing. But what I was thinking within the neuroscientific point of view in that case is what makes these kinds of tumors resistant, give those tumors the longevity, because you see it's not the challenge to take out the meningioma, and in this case those are rare. You don't have too many biological samples out there that you can pull up and then conduct some pure basic science, and then you have to use radiation therapy when even though the Ki rate is very high. What makes you think in these kind of tumors, especially subtype of meningioma, is they are slow to grow somehow. Yes, you showed us the images that recurrence rate was very high in recent 3 years and growing, but I'm always curious, and I wonder what's the makeup composition of the cellular makeup of these specific tumors that grow slowly somehow, not as fast as a glioblastoma, and then are resistant, and we don't have a chemotherapy on the side to help these patients. It's just a question I wonder. So if you want to share your thoughts, it would be great.
I mean, I don't have a good answer. I'm, very concerned about when this man comes back with another recurrence, because then what are we going to do? We've kind of used all our salvage options. I think these aggressive meningiomas occupy a really special niche with their biology, right? So they're not replicating fast enough that traditional chemotherapies work, but they're replicating fast enough that they outrun kind of all the things we try and do. And this guy's in his 40s, so he's not someone, you feel really comfortable being like, well, I'm sorry, sir, we don't have other options for you. And so I think these cases are just getting more and more challenging. There's some, trials going on with like Avastin or tumor treating fields or combinations and things like that. They, at least in my experience, only seem to provide sort of limited benefit, but we'll see what comes out next. I wish I had a better answer.
No, thanks. The honesty is a great answer. You know of anyone that it has out there and pulling out and reaching to collect samples or have biological tissue samples sent to them, and then maybe is conducting a more thorough basic science work on that end, or it's...
Yeah, I mean, I think the Toronto group, 𝐀𝐂𝐍𝒒, they have that international, I forget what it's called, the International Meningioma Consortium, I think, where they're sharing tissue, and they've done all the methylation work kind of recently. Stephen McGill does a lot of this kind of stuff, but I think it's still kind of early stages, but hopefully we make some headway.
Thanks. Thanks, Doc.
Right. Do you have anyone for any questions? Prof. Takashi, you want to ask anything?
Thank you, Jared, for the nice presentation. I'm specialized in malignant brain tumor, so brachytherapy, sometimes I'm very interested. And combined with the radiation and gamma knife and treatment, so brachytherapy efficacy was found, but invasive one or aggressive one, or sometimes a malignant one. How do treatment treat? So removing the tumor as possible is a standard. But sometimes deep-seated one cannot remove at all. So in that case, so how with intensified brachytherapy, intensified radiation, how do you think for the treatment for very stubborn malignant such kind of meningioma?
I think, the implanted brachytherapy, because of the dosing and the fast fall off, only really works in a setting where you can get a good resection. So that's a real challenge. There are some cases I've seen where, and I don't know how much you guys are using these tubular retractors to kind of protect the brain as you do the corticotomy and get down. So the brain path, which was used in the ENRICH trial for ICH, is one of the tubular retractors, but you can actually do, the resection through that, and you can place gamma tiles through those tubular retractors to try and get at some of these deeper lesions with less disruption superficially. But if you're not able to get, at least in the glioma data, it seems like you're only able to really effectively treat or get a clinical dose to about 5 millimeters. So if you're not able to at least shave it down to a very thin rim, at least this type of brachytherapy is not going to get you the benefit you're looking for.
Thank you. Thank you.
Prof. Kato, you want to ask any questions? Okay, so we can, I think, thank you so much.
Excellent talk.
Yeah,
Thanks.
thank you very much, Angela. It was a very interesting talk. We'll go on to our third and final speaker, Prof. Yang. Prof. Yang is a chief physician, associate professor and supervisor in Beijing Tiantan Hospital. She's also the executive deputy director of the Center for Brain-Machine Interface Translation Research, National Center for Neurological Disease, Beijing, China. So today she will give us a very interesting talk on the consciousness-related neuroanatomy. Prof. Yang? We can't hear you, Yang. You're
Can you
not
hear me? Can you hear me now? Can you hear me now?
Yes, I
Can
think
you hear me now?
yes, we can hear you.
Okay.
Yeah, I think you need to start again because we didn't get the first part.
Okay. Sorry, wait a minute. Can you hear now?
Yes, I can hear you.
Start here.
Oh, Yang, I can't hear you again. I think something's wrong. Is it your internet or we don't seem to be able to hear you?
Can you hear now? Hear me now? Can
Yes,
you hear me now?
yeah, I can hear you now. Yes.
Okay, I will start it right here. Okay.
Okay. Yeah, okay.
And
All right. Okay.
the consciousness remained a long-standing puzzle in nature science, promoting awareness of one's thought, feeling, sensation, and the surroundings. And the current study emphasizes the brain active patterns, interacted network, long-range connections, and neural synchronization with a specific frequency range. The researchers delved into these details into uncovering now the brain generate personal experience and the mental state, aiming to Eurable of the mechanism under the consciousness. And the consciousness consisted of arousal and awareness. Arousal, primarily supposed by the brainstem and Salome, remained the wakefulness for the peoples. And the awareness, it managed by the cerebral cortex, involved the conscious perceptions and some cognition past and the present experience and some intentions. And it further divided into awareness of the environment and which include the sensory receptions and the country understandings, and also the awareness of oneself, a mental process independent of internal stimulate. These components reflect the various levels of consciousness in both physiological and pathological conditions. So from the perspective of clinical anatomy, the main structure of the effector consciousness include the brainstem, the ascending reticular activity systems, and non-specific thalamic nucleus, the well-defined areas of the cerebral cortex. It can be seen that a line is drawn with the midbrains as a plane, and the structure below this lines is mainly related to awakening, while the structure above the line is related to the awareness, including completely cognitive functionals. And also in the common patients, we can know several of the bilateral attachment from the midpoles to the upper midbrain result in the consciousness loss, and meeting the consciousness requires the intact connection between the poles, the midbrains, the brains, and also the 𝒀𝒊𝒏𝒂. The bilateral 𝒀𝒊𝒏𝒂 severance lead to the pertainment and the irreversible consciousness loss, and the lesion of the cephalad middle brain, notably the basal ganglia and the middle hemisphere, has a greater impact on the consciousness than those in the tegmental and the 𝒀𝒊𝒏𝒂. The common patients, there has a largest overlapping lesion areas concentrated in the core of the supreme potens tegmental nucleus, including the NR, LC, LDT, and the PPTG, PNO, and PPN. The unitary lesions in common patients are near the middle eyes and the posterior tegmental, while those in non-common patients are in the lateral and the atris tegmental. In our research, we found that in the pulsing tegmental areas, PTA, and the caudal midbrain areas continued to fall unique clusters, which especially shows the extensive connections with the cortical network supporting the internal or external consciousness of the health individuals, and comfort their roles of awakening. The patients with MCS or WUS, the functional connectivity of the PTA and the caudal midbrain regionals to the cortical consciousness support network decreased significantly. And also the ascending reticular activity systems begins in the low brainstems and extending upwards through the pores, the midbrains, and the thalamus. The project throughout the cerebral cortex, wherein two passes. One is through the subthalamus, and another one is the thalamus. The state of the weakness of the mediates by the RAS neurons with neural pathways from this location projection and throughout the cortex, responsible for awareness. And also the reticular formation has affect and effect connections. The rostral part start around the upper pons and the midbrain contain neural group that project to the cerebral cortex and either directly or wearing the thalamus, playing very important key roles to the arousal and attention and emotion reactions and learnings. The caudal part located in the low pores and the middle project to the spinal cord, and it involved in the motor functions, the respirations, and the blood pressure regulation. And also the third kind of the important key is the thalamus. The thalamus active as a major sensory relayed stations, and in the integrating center of the most impulse to the cerebral cortex. It maintains the consciousness and alertness through the ARAS and contribute to the subcortical sensation perceptions. It controls the muscle movement, wherein the connections within the basal ganglia, the cerebellar, and the motor cortex, and serve as integrating center for the sleep, for the electrical activations of the cerebral nucleus, include sleep, consciousness, and other movement disorders. The neural anatomically, it is divided by the internal medullary lamina into three nuclear groups: the lateral group, the medial group, and the anterior group. And the interthalamus nucleus receive affect fibers from the brainstem's reticular formations, and the spinal thalamic and the trigeminal lamina and the GPI, and also the cerebral cortex. Their effective fibroid project to the cerebral cortex, wherein other cerebral nucleus without direct cortex connections. And this nuclear influence the level of the consciousness and also the awareness, the integrate of the semantic and some auxiliary sensory implants before the projecting to the context. And in a recent study is at the end of the year of 2023, this study published in Nature Medicines. This is more clinical trials aim to assess safety and effectivity of the deep brain stimulations in the central lateral nuclear and the related medial dorsal tegmental layer of the thalamus. That is the middle thalamus, a key of the brain circles. It stimulates with about 150 Hz. And the result indicated the potential to enhance the cognitive functions of the patients with a long-term cognitive impairment result from traumatic brain injuries and a short time into the coma. Improvement of about 10% from the baselines to the end of the treatment phase, and the average improved is about 31.55%. And in our recent submitted clinical research, this is research article, we conducted the DBS implantation surgery target the central medial paraphysiological complex on 8 patients, and we found that 100 Hz stimulate demonstrated the clinical effect than the 50 Hz stimulate, and have a good result. The auditory, the visual, and the communication subscores shows a significant enhancement under the 100 Hz stimulate. And the last very important key areas is the cortex, is the well-spanned areas of the cerebral cortex. And the extensive cortical connections reflect the brain multiple functions and the neural interactions. A large neuron project to the cortex wearing the thalamus, and small adreneric neural connect wearing the intrathalamus nucleus of the thalamus, and noradrenergic neural project to the cerebral and the dopaminergic neurons to the beta ganglions, and the stenotogenic neurons to the thalamus. The cerebral cortex, the hypothalamus, and the limbic structures. And also with the development of the neuroimage technology, the neuroscientists are constantly looking for the key areas of the widespread areas of the cerebral cortex, and determine consciousness, which is determined consciousness, and through the PET-CT, the functional fMRI, and some brain network methods, people has gradually discovered the midline structure, especially the default network in the brain networks, which will play a great role in how to distinguish the level of the consciousness. And however, it's available in the clinical practice, need further observations. Also, this is another our studies. We use the networks based on the whole brain functions. That is the default network, the executive control network, the silence network, the visual and auditory, the motor sensory network, and some patients' informations is established model that can predict the further prognosis of the patient with disorder of consciousness. So in clinic, we can see all the kind of the patients with common that and also maybe some people, maybe some patients become a prolonged disorder of consciousness caused by the different brain injuries of these 4 very important areas in the brain. And there are some diagnoses about the disorder of consciousness after a common exceeding about 28 days. The patient usually start to automatic eyes opening and regular sleep-awake cycles into a vegetative state, and progressing in the futures, they might shows the proper movement and like location the object, marking the shift scenes, and maybe they go into the minimally conscious states, and then if they can following commands, they get into the minimally consciousness states plus, and if they can communicate functionally, we see they have recovered. We usually use the CSR scan to measure the level of the consciousness, and all these diagnoses are based on the physical examinations of the neural systems, which is also directly related to the neural and anatomy. So in the common patients, the specific brain stem areas can cause various changes in the respiratory and the pupil response, consciousness harming on the interaction between the intact cerebral hemisphere and the ARAS in the brainstem, the middle brain, and the hypothalamus. The lesion affect their areas, impair the consciousness, and particularly those impact the cerebral hemisphere and directly affect the ARAS. And for the neural anatomy of the consciousness, from the anatomy to the treatment, this is a very famous hypothesis. It's called the 𝑣𝒂𝒂 model, which explains the connection between the thalamus to the cortex, and the different treatment aims at different targets and neural anatomic mechanisms. In clinical, we can give the corresponding intervention according to the state of injury and the clinical manifestations of neuroclinical examinations of the treatment magazine. This is one kind of patients with severe damage of the brain, mid-brain structures, and there will be a cortical rigidity. And when we observe the large scale network of the whole brains by the functional fMRI, we will find that this default network that which can affect the consciousness is a very serious damage, and such patient may in the clinical way we may think they should consider the cortical stimulations or deep brain stimulations. And another kind of patients which the brainstem injured below the right nuclear structures that has they will have the degenerative rigidity. And when we observe the large scan network of the whole brain by the function fMRI, we will find that the default network, which is very important to the consciousness, is well preserved. It's very interesting. Such patient may need to consult by the spinal cord stimulations. And also in clinical, we can combine the injured site with the peripheral stimulation, the cortical stimulations, and also the combined stimulations, the deep brain stimulations, or spinal cord stimulation, vagus nerve stimulations, and so on, to help these patients recover the consciousness and the functional. And this is case, a young man, 31 years old. They have a traumatic brain injuries for about 6 months after a comment from 1 month, and the diagnosis is minimally conscious status. He can visual tracking and the pain localizations. His series scores shows the incremental programs after the DBS stimulations, and they at last have a completely recovered of the consciousness. And this is before the DBS operation. And this patient's EEG changed during the moment of the stimulator activation, and the deactivation can be observed. And when we use the 25 Hz, the delta power increased in the right frontal regions, and the theta also shows a notable increase in the occipital injuries. But when we use 50 Hz, the delta power increased in both frontal region, and the theta increased during the stimulator, but returned to the baseline after the stimulation. When we use 100 Hz, the delta power increased in the left frontal areas, and there is a decline trend after the stimulation. The theta decreased during the stimulation, but returned to the baselines after the stimulations. And also in the primarily investigation of the individual fields potentials, we also found that the high frequency stimulator at about 100 Hz inhibit the thalamic field potentials in the delta and the theta frequency band. And moreover, the patient up on the stimulate activation, they have transitions from a sleep state to a wake state with about a delay of 4 to 10 seconds. They can sleep, they can awake when the stimulate on after about 4 seconds. And under the 100 Hz stimulation, after a period about 5 months, these patients exhibit a significant improvement in the level of the consciousness, and the LFP spectra shows marked reductions in the delta, theta, and alpha powers, while the beta, the low gamma and the high gamma power exhibit the significant increase. Also, after a 5-month stimulator followed the DBS, there was a elevation of the level of consciousness. The stability of signals and in the delta and alpha frequency bands showed a significant increase, while the stability of the signals in low gamma and high gamma frequency bands exhibit a significant decrease. And furthermore, after 5 months stimulate following the DBS, there was also the power spectral slope in 1 to 40 Hertz range increased, and while the power spectral offset decreased. And in this analysis of the instantaneous stimulate effect, different power across the frequency bands before, during, after the DBS stimulation was observed. When the DBS on, there was a significant reductions in the delta, theta, and alpha powers, while low gamma and high gamma power increased. And when DBS off, the energy level returned to the state before the stimulate were initiated. And the current finding demonstrated that during instantaneous stimulate and the trans change induced by DBS may serve the potential neural biological markers. And this is the young man stimulate about 5 years later, and they recover the consciousness and some functions of the motors, and they can understand the environment, and they can communicate some feelings, and the motions can be communicated with the families. And that is our studies about the neuromodulations for the disorder of consciousness, and also some neuro anatomy about the conscious. And thank you for your attention. This is our hospital, Beijing Tiantan Hospital, the largest and the most comprehensive neurosurgery centers in China. And in the field of neurosurgery, we have constantly ranked first nationwide for the past 7 years. And you are very welcome to visit our hospitals in the future. And thank you very much.
Thank you very much, Prof. Ling Yang. It was an excellent presentation. I think showing hope in patients with severe traumatic brain injury. Okay, the floor is open for questions. Our discussants. Prof. Takashi,
Yeah.
Prof.
Thank you for a great talk. So as for thalamus, so no, not completely understood, but your lecture and your review of the paper, the system of consciousness is became very clear. So I'll review the articles and try to learn and studies. But how do you think this is the multiple factors about consciousness, but any factors, so that function of thalamus, the very important that some the part of the thalamus, so the divided as functionally divided. Are there any factors affecting not only anatomical structure? So are there any factors regarding the conscious disturbance or conscious awakening? So how do you have some opinion other than anatomical function networks, other than hormonal or some other electrolytes or something?
the questions. And in my opinion, the thalamus maybe is the key to start the consciousness, but it's not the key to maintain the consciousness. So we should do some deep brain stimulation in the thalamus to start it, to let the consciousness get start, and the context, salivary context, we should do some stimulate such as TMS, TDCS, or other things that can remain the exciting of all the brain, the whole brain networks, and let the net brains get more activities and more connectivities that can maintain the consciousness. So in the thalamus, they also have some spark, some start to file the consciousness, to start the consciousness, and in the cortex, they have some exciting neural activities to maintain the consciousness, so they can have some repair of the neural circuits to recover from the disorder of the consciousness. So I think the maybe the frontal regions and some motor regions, that is all the important areas for the consciousness to remain. Yes.
Okay, thank you. So
Okay.
we expect the future study and the future that will be areas clarified between the brainstem and hypothalamus and thalamus relationship. Thank you for the presentation.
Thank you. Thank you.
Yes, Hui-Pap, you can go ahead.
Thank you for the interesting presentation. I'm a brain tumor surgeon, and I have a question that for the patient with lesion in the brainstem or in the thalamus, do you think in the future there will be some modality to monitor the consciousness for the patient undergoing surgery in that location under general anesthesia to detect any potential impairment after surgery regarding consciousness?
That in clinical, we always do some simple neural examinations for the patients to test their level of the consciousness, and also we can have some other test. For example, the fMRI, the functional fMRI, or the EEG, the MMN, TMS EEG, or other neuro physiological and neuro in imaging technology to observe the level, the degree of the consciousness, so we can exactly know how much, which level they are on the different degree of the consciousness. So different degree or different kinds of the consciousness, different compose of the consciousness, we should use the different treatment for the patients. So maybe in the futures we should do more development for the test to the patients about with the disorder of consciousness.
Yeah. Thank you.
Prof. Suresh?
Yes. Seb, it's a nice presentation, and we are trying to learn the basic neurology. That's good. My question is that, say, is there any role of Pepper circuit to be played in the consciousness? The limbic system, you talk about the interlaminar nuclei and hypothalamus. Are there any other structure which are involved in the consciousness? Number one. Number two is there any difference in contribution of the left-sided or right-sided hemisphere, or both contribute the same? there is no voice, please.
Think so. What is the first question exactly?
First question is about the limbic system, the Pepper circuit. Does it have any role to play in the consciousness, except that you told about the intralaminar nuclei and hypothalamus? Is there any other structure in the limbic system which has some role to play in the consciousness? Number one. Number two is there any difference in the contribution from the left hemisphere or the right hemisphere? These are the two.
Yes, they have because the consciousness is a very complex problems for not the medicine, also for the physiological or the other neuroscience thing. We can't explain the consciousness very clearly. So for the patients, we just think the consciousness combine the arousal and the awareness. The one is the sleep things, the sleep and awake, and another is how they respond to the environment and their self. So if this is just a response to the environment, we can use a lot of neurologic examinations to assessment it, and the different kind of the consciousness. Until now, we can't explain it very clearly. I think maybe I don't understand how to explain the difference between that. Yeah.
Sharon?
Yes. I think it's a question from Prof. Angela.
Oh, I was going to ask about left and right side and if it mattered with the stimulation.
Right. Okay. I guess.
Abhiza, you have done lots of dissections about these deeper structures in the brain. You must have read about the functional anatomy and the physiology in these areas. Abhiza, will you be able to contribute something in this about the questions which I asked?
Not sure how much of the Pepper circuit will actually be involved in consciousness, because it basically goes to the reticular activating system, to the thalamus, and to the cerebral cortex. So it is a circuit that is outside. So the limbic system, only the anterior nucleus of thalamus is involved. And I think the nuclei that were involved that she showed us in this presentation were the other nuclei. So probably I'm not sure if the Pepper circuit will be affected in, will be involved in consciousness.
What about the left and right?
I don't think it should matter because it's coming to the thalamus ultimately and the brainstem.
Okay. Thank you very much.
So I think, there's a question from Toivo Hashila. Would you, I need to enter you into the, okay.
State of consciousness of vegetation or MCS. It's a good question. And DBS, we use the target CMPF. It can improve the consciousness and also can improve the behavior, the motor functions of the patients. So if the patient is in a vegetative state, what he lost is the response to the environment. So we maybe put the electrodes deep in the CMPF, so they can stimulate the PF more than CF. They can improve the consciousness, the awareness for the patient more. And if the patient is in MCS, maybe he have some response to the environment, but they can't explained himself. They can't do the some behaviors. So we maybe stimulate the CM more than PF that can improve the motor function more than the response for the patients. So the medial thalamus, they have a lot of functions maybe put together. So when we use we do the operations, we maybe choose the different sub area of the nucleus, or maybe we can use a different frequency to stimulate. So we can also improve the consciousness or the behavior in the vegetative state and MCS patients.
Okay, thank you. I think one more last question from Hashila. Hashila, you can go ahead.
Thank you very much for the opportunity. Thank you very much, Professor Yang, for the detailed presentation. My question was previously partially answered in the previous question. My question was going to be, have you in your study come across patients with a so-called locked-in syndrome, and was there any benefit from the stimulation?
That is a very good question. Before the last year, when the Nature Medicine paper published by the Professor 𝒓𝒄𝒄's teams, before that, they always they always treat the patients for the disorder of consciousness, and in that studies they changed the their fields. They use the CL nucleus for neurostimulations, and they want to improve the quality of the patients. So maybe the deep brain stimulation can improve not only the consciousness, but also a lot of other functions for these patients, such as the lock-in patients. But until now, if we have some evidence for the lock-in patients, maybe the neuroimaging, maybe the EEG, they can find that they have some awareness. They can understand all the comments, and if they can do that, we can diagnose them to the lock-in patients. And if they have the diagnosis, maybe we can use the BCI technology for the moment can help the patients to let them motor motions use the other computers or the some robot to help them to explore their mentions, not to do the neuromodulations for the patients to improve their consciousness or other awareness or the memories or other things. So the patients with lock-in, we think they have the full consciousness, but cannot do any cannot have any motor functions. So maybe BCI is better for the patients.
All right, thank you very much for the answer. I'm a fellow here at Fujita Health University under the mentorship of Professor Yako Kato. Thank you very much.
Thank you so much for joining us. Prof. Kato, do you want to say anything before we finish?
Okay, thank you very much. So just I want to ask Dr. Yi, thank you very much for very precise presentation. I was very impressed your talk. Just, everybody wants to know when the patient will recover back to the normal life. So can you predict with your research, or can you tell the family of the patient how soon the patient come back to the better state prediction?
That's a very good questions. And until now, we just all the research we just have pronounces how whether they can recover or not, but they do not know what is the time window for the recover. So that is very a good question and a very interesting project to studies. And in our opinions, during the clinical experiment, we found that if the patient they don't injure the key areas, the 4 key areas in the brain, they can recover at last. No matter what stimulation technology, what treatment they use, they can recovered. And also they have they should have some good environment. They should have the family maybe have a good situations and other things. But if they don't injure the key areas, they will recover. And the time window is about 3 months to 6 months after the coma. And if they don't recover after 6 months, the rate of the natural recovers all the treatment effect, it maybe decreased about half rate. So 3 months and 6 months is the most important time for the common patients. Yeah.
Thanks so much. So I think the other 2 talks are also very excellent. And Marina talked about endovascular treatment. So I think the day by day the devices improving in the vascular area, I think. So my feeling, so almost no open surgery in the future, because maybe the robotic can do the bypass surgery in very near future.
I don't agree to you, Professor 𝒂𝒂. No open surgery is, I don't think so.
In the near future, I think, because the endovascular team is fighting with open surgery every day. But open surgery is almost a very classic, a very slow, I think, improvement.
Say, you had been to PGI so many times, Dr. 𝒂𝒂. We still continue, though I am not there.
Yes, of course, I do the open surgery every day. But even though, just I want to congratulate Marina. Please continue your work.
No, that is fine. Still, we are operating around 420 aneurysms a year.
Yeah, it's okay. The congratulations.
So
thank you so much for your comment. And also the Angela, as always, your talk was very good. Kind of the malignant tumor, malignant meningioma. I think please continue your research and tell us in the future the more improvement the results. Thank you so much. Thank you, Sharon.
Yeah, thank you everyone for joining us. Have a good week and good night. Bye.
Good night.